If the patient's gonna die before they get to the OR, then the benefits outweigh the risk.
Sorry. What? What is happening now? Hello, my name's Ed, your friendly neighborhood emergency doctor, and I've had so many comments to check out episode 12 of The Pit, so we're going to fast forward a bit in our reactions and check that episode out. But don't worry, if enough of you want it, I will go back and look at the other episodes too. But here it is, episode 12 of The Pit.
Sure, it's okay. Active shooter at Pitt Fest.
We heard.
So this is what it's all about. We have an active shooter at a music festival. In the UK, we'd define this as a major incident, so an event that essentially outstrips the available emergency response. It might be surprising to hear, but as emergency doctors, I mean, in the UK at least, we don't get specific training on how to react to this. I think because of the gun culture in the US, that might be very different out there. But there are courses that we can go on to learn more about it. So I've done a major incident course before, so I might be pulling on a bit of that knowledge in this reaction.
We're gonna need more help, especially from surgery and anesthesiology.
MCI group text and emailing out to everyone, including transport and environmental services.
Okay, good. Hey, everyone's gonna wanna come in to help. Keep enough in reserve. Tell them to come in 8 hours later to give us a break.
But already we see Dr. Robbie handling it like a champ. So he's thinking ahead in the next steps, ensuring that there are doctors sort of staggered that are coming back for the following shift. Because situations like this require such a big organizational effort. You need to have the ability here to zoom out to see the bigger picture as well as deal with the thing that's immediately in front of you.
You're gonna need all 25 ORs.
Ahead of you. 4 ORs are prepped and staffed, and we're working on getting the rest up and running.
What about disaster supplies?
On their way.
Every patient in the ER needs to go up, beds or no beds.
What a great initial response. The clarity of thinking in terms of this plan is pretty impressive. And because this is such an organizational crisis, these moments before patients coming in are absolutely critical. In reality, though, this wouldn't happen here on the shop floor between two people. One of the rooms in the emergency department would be designated as the control room, where an emergency meeting would be called and involve all the senior leaders from the hospital management to the medical and surgical teams, the theatre teams, the nursing team, the ambulance service, and various other important hospital services. It's super important that staff understand the new patient flow and the chain of command, as usual procedures won't necessarily be followed. I say won't necessarily, probably won't be followed.
There is an active shooter at Pitt Fest. As the nearest trauma center, we are going to be getting the majority of the victims. We don't know yet how many we are getting, but we are instituting hospital-wide emergency protocols.
So although I said the planning would happen in a control room, this is how we'd find out as doctors. And frequently we get updated about issues in the emergency department with, you know, a big old-fashioned announcement round the nurse's desk.
OBGYN, CCU, ICU, ortho.
Very good. So we see here the whole hospital springing into action with patients going direct to the specialties. And the same thing happened during COVID, where ordinarily patients would be assessed by emergency doctors and only referred to specialties if we needed their input. Whereas in COVID, to keep the emergency department cleared and to make sure we had enough capacity to deal with patients that had COVID, we were allowed to triage patients direct to specialty, bypassing the emergency department. So a similar thing is happening here, although I guess the difference between this and COVID is we had days to prepare. They have just a few minutes.
MCI protocols.
Make sure you bring all these gurneys and wheelchairs back to go into the ambulance bay.
Yep.
We need as many as we can get our hands on.
Already, we're seeing the hospital sort of spring into action. Again, we see Dr. Robbie thinking ahead with logistics of needing trolleys and wheelchairs. I mean, it's hard enough to find a wheelchair on a normal day, let alone a major incident. And we see the nurse in charge, Dana, has put on a high-vis vest. As we mentioned before, how important it is to understand the chain of command. So that's one step to help that.
Okay, everybody listen up. This is how it's going to work. Our ambulance bay is now our triage. EMS will be overwhelmed. Most will probably arrive by car, several victims per vehicle. Triage will decide who goes where depending on their injury. No patient goes into a room unless it's a trauma bay, and they will have 4 patients each. We need to keep everybody out in the open so we can keep an eye on everything.
And we hear about the new patient flow being communicated with the team. And important to note as well, this kind of triage would also be happening in the incident zone. Different places around the world will use different triage tools. Here, I think think it's the START triage they're using, which is almost identical to the MIT triage we use in the UK.
Triage is going to assess and assign every patient to a specific zone with the colored slap band. Patient who comes in with a red slap band goes to the red zone, which is the trauma rooms with overflow out here.
So these are patients that typically have an airway or lung injury or are hemodynamically unstable, so significant bleeds or multiple traumas. These patients are likely going to need surgery, so the job of the ER team is really just to stabilize them as much as possible, so secure the airway, limit any bleeding, transfuse them some blood, and then get them prepped for the operating theatre.
5 minutes to try and stabilize the reds. After that, it's OR, ICU, or morgue.
The South and
right.
Central.
So already they're mentioning the morgue here. With the large number of patients, even with an excellent response, you may have someone that dies that ordinarily you'd expect to live. With the limitations on resources, you aren't going to get patients to the OR as quickly, or if someone arrests, you might not be able to run a code on them.
Common area over there will be the pink zone. That is for patients who will die in under an hour without treatment. McKay and Javadi, you were over there with help from incoming night shift.
Then we learn about our pinks. So these are people that may have very similar injuries, but are generally a bit more stable.
Yellow zone is the north corridor. Those are going to be mostly extremity wounds. Good vitals, talking.
And then we hear the patients that will get a yellow band. So these are patients that would have normal vitals, but perhaps extremity wounds that could get worse if the bleeding's not controlled.
Green, minor laxant sprains, they go to family medicine.
And finally, we have the walking wounded. So they'll be wearing a green band, and these are people with very minor injuries.
But a yellow can change to a red if they go south. You got to stay on top of them, even if they seem stable.
Okay, yeah.
You got this, Doctor.
Yeah, exactly this. Triage will be happening constantly from when a patient's first seen in the incident zone. They may be triaged again before they leave the incident via the casualty clearing point, and then again when they arrive at the hospital. And it can easily be the case that someone deteriorates and changes from one priority to another, particularly because, in my experience, bleeding only happens in one direction.
There's no charting, no electronic medical records, no board. Sharpies, and every patient has a wrist chart to document treatment and procedures. You run out of room, right on the patient's forehead.
Really?
Yeah, really.
Each wrist chart has...
Yeah, writing on a patient's forehead. I have been taught this from the major incident training, but I've never heard it for documenting drugs and procedures. The only time I've heard it being used is for forward triage. So if you're the very first person at the incident, writing the priority on a patient's head with a marker pen is a great way of telling everyone else that they've been assessed and what priority they are. I could see it being somewhat problematic if we start writing the drug names down, because some of them are pretty long. Like, you'd be like, hold still. How do you spell acetaminophen?
Assessed based on mental status and pulse strength. Every critical patient gets an IO intubation.
Ooh, an IO. Are you guys ready for this? Because spoilers, I think we'll probably see a bone getting drilled.
Goal is to triage each patient in 10 seconds.
10 seconds. Got
Mental
it.
status is AVPU, alert, responsive, verbal, responsive, pain, unresponsive.
Telling a fellow doctor what AVPU is. This is incredibly basic information to be saying to another colleague, so this is purely for the audience's benefit. AVPU is a rapid way of assessing consciousness. We've talked in episode 2 about using GCS, so the Glasgow Coma Score, to assess consciousness, but AVPU is something we can do in seconds rather than GCS, which can take a few minutes.
Tells you where to send them. That's it.
Yay. Pull. Heard about it rain today.
John.
How can this guy be so chill? I'm not sure if he's the absolute boss with nerves of steel, or he's just so overwhelmed with stress and showing signs of resignation. I guess we'll find out.
Relax. I got the front door. You worry about the back.
Show me. Right chest, strong radial, pink. What's this? That's priority boarding. You're going to be okay.
Okay, first patient up. So he's alert with a strong radial pulse, but a significant chest injury. So he is a priority pink. This guy could easily turn to P1 very rapidly, which is kind of scary because ordinarily this would be like the sickest guy in the ER. And, you know, we're going to see people much worse.
Sir, can you hear me? Black and white, peds.
And we have our first patient that's expectant, so, you know, dead or just about to die. So given the resources available, it's inappropriate to run a code and try and resuscitate this chap. In the UK, in a major incident, in order to be able to triage a patient in this category and therefore not do CPR, requires authority from the government.
Red zone. You need to let go now.
Oh, I want to stay with my son.
He's got a gunshot wound to the right chest, so we'd be worried about a collapsed lung and bleeding, so a pneumothorax.
What happened to your leg?
I got hit by a car when we were wheeling.
Okay, we'll see you inside too.
I love that. Isn't that just like the coolest triage you've ever seen?
Okay, we'll see you inside too.
Man, all the cars building up here is already giving me anxiety. Like we said before, major incidents are all about organisation, and if you've got a massive traffic jam outside the hospital, that is a major risk.
Stronger pulse. I'll take her up. Dr. Mohan, that kid came in with his mom. She says he's deaf.
Ready to go with the ONEG.
As we thought, the first patients we saw had a pneumothorax, so blood in the thoracic cavity. So we put a tube in his chest to help drain that blood out, help the lung inflate, and to help his breathing.
See who needs help.
IO's in, go with those.
And here we go. As promised, we see our intraosseous access. So when people have lost a lot of blood, their veins can collapse, meaning it's harder and therefore can take longer to try and get IV access. It sounds mad, but another option is to drill into the bone and put access in this way. To be fair, I thought they'd make it really dramatic that we're drilling into bones, but actually they've kept it completely normal, which it absolutely is in this situation. The usual site to place this would be the head of the humerus, like we see here, but other common places would be your tibia, so your shin bone, and your sternum.
When there's no time, bone marrow infusion's as good as an IV.
Yeah, okay, it's not quite as simple as that. The infusion rate, so how quickly we can give a patient fluid in an IO, is less than an IV, although this can be mitigated somewhat by pressurizing the fluid bag. But as we said, the real advantage is how quickly you can put an IO in and its rate of success compared to an IV, especially in an unstable patient when their veins have collapsed.
Document the tourniquet time, mark the arm, mark the chart. Let it down briefly once an hour, okay?
And we're over in the yellow zone here. Patient has a vascular injury to the right forearm and they put a tourniquet on and she's screaming in pain. Likely not from the injury, but just how tight you need a tourniquet in order to stop arterial blood flow. Very important, as they point out here, is to time how long the tourniquet's been on, because it's stopping any blood flow down the arm to stop you bleeding out. But if it's on too long, you're going to start getting the tissue in the arm dying and you could potentially lose the arm.
Oh, looks like closed tib did fractures. Strong pedal pulses, great flow with the butterfly.
Is this episode sponsored by this butterfly ultrasound company? Because they've referenced it like 3 times now. If so, and they want to sponsor my videos, give me a call. Joking aside, my previous hospital had 3 of these and they were actually incredibly useful.
Unresponsive, had a weak femoral, lost it.
2 units of blood. There's no response, call it. No pulse, no OR.
Gunshot to the head.
Through and through.
Yeah, we still got a strong pulse. This one can make it because the intracranial bleed can decompress through the bullet holes.
Walsh, neurosurgery in-house.
Wow, it's difficult to keep track of all the patients, but this one here has a gunshot wound to the head. So any head trauma, what we really worry about is bleeding inside the skull, so an intracranial bleed. And because the skull is a fixed bony object, as that blood increases, it can squash the brain, and this is what essentially can kill you. I don't know if it's right to call this lucky, but in this case, the doctor points out that the bullet has gone right through the skull, essentially giving the patient 2 holes in the skull, making it less likely that an intracranial bleed will kill them because the pressure can be relieved through the holes. I mean, I don't know how accurate that is, but in theory, that sounds okay. And if so, it's one of those weird coincidences where kind of a worse injury is potentially better for you. Cool. I love how much detail they've gone into here. So we've got the main shot, but also everything that's happening in the background. So here we see Dr. McCabe pulling out the guide wire from a chest tube, which is just great attention to detail and adds to the realism. In trauma, we can actually put chest tubes in without guide wires, what we call a surgical chest tube. But here should be using the Seldinger technique, which is where we put a needle in with a guide wire, and then we use a tool to make the track larger, and then slide the tube over the guide wire to get the tube in the correct position before removing the guide wire like we see here. Then essentially we'd have a one-way valve on that tube to help expel any air and therefore help the lung inflate.
For proper chest tube placement, keep going until the last fenestration is intrathoracic.
Stop.
What?
I don't need you teaching me right now.
A medical student putting in a chest drain, that's not going to happen. You may feel that in an emergency you need all the help you can get, but actually supervising someone to put in a chest drain is going to take way longer than actually doing it yourself, and they're more likely to make an error too. So this is really not the time to learn. Anyway, this time we see a surgical chest drain, so putting it in without a guide wire, and this uses blunt dissection, so opening up the thorax with forceps. So the patient likely has a hemothorax, so blood around the lung that needs draining.
I lost a radial pulse.
From a broken leg?
Well, what did we miss?
I don't know, heart attack, another injury from the car crash?
That's for pulses.
It has an EFAS mode.
Oh, the butterfly has an EFAS mode. Yes, that's right. The butterfly ultrasound has an EFAS mode too. Get yours for only $1,000 and be sure to use my discount code Dr. Hope for 30% off.
Diagnosis made. Blood in Morrison's liver laceration.
Car hit the belly, leg was a distracting injury.
Yeah, so with our very useful fast scan here, we find out there's blood in her abdomen. So she is going to need to have an urgent laparotomy. So she needs to be opened up in the OR to stop the bleeding. So our first patient that switched her priority. And so far, the whole team are doing a fantastic job.
Leg is low priority right now. If she stabilizes with blood, she can wait an hour for the OR.
And if not?
Front of the line, baby.
Your son's in the OR with the GSW of the chest.
Sweet. Family reunion and post-op.
I love that delivery. That was so action hero.
Sweet. Family reunion and post-op. Fast negative.
Help me, roller.
Tim, Ampa D50 now.
Got it.
Seriously?
Look, glucose monitor. She's diabetic and probably hypoglycemic.
So check a blood sugar.
No time for that. She's in a coma from low blood sugar. Will you look at that? These are healing hands.
Too bad they're so tiny.
Yeah, I mean, that is an absolutely brilliant catch. It could be so easy to get swept up here and look for a sort of traumatic cause of her loss of consciousness. But we are taught, even in trauma, to do a full A to E assessment. And within the disability section, we must consider things like hypoglycemia or alcohol or toxins that could affect a patient's conscious level. So great work, because if it had missed that, it would have sucked in so many resources unnecessarily.
No, just give me one good push. Yep. Okay, give me two. And do it again. Okay. I think I am in. Back him.
Check the end title.
Yellow, we're good.
How did you do that?
Bubble intubation. You gave the compression and followed the air bubbles up more than one way to tube a cat.
Bubble intubation. Well, I mean, that's a new one for me. Probably one of these things that's only happened like a handful of times, but these medical shows like to throw it in, as a bit of a flex. But it makes sense. Air's coming from the trachea. The tube needs to go in the trachea. Every day's a school day.
Intubated chest tube, but massive subcutaneous emphysema. Air from the chest is leaking under the skin. Loosen the pulse.
What do you think?
Tamponade from pneumomedius sinum.
Cool. Yeah, so we see a patient with surgical emphysema or subcutaneous emphysema. This is what happens when air from your respiratory system has a passage into the rest of your body. And when you feel subcutaneous emphysema, it feels really crunchy when you touch the patient. Usually it's not an emergency if there's a small leak, but yeah, if it's building up this quickly, it can start squashing the heart and big blood vessels around the heart, what we call a tamponade. And that's what they think's going on because this patient has lost their pulse.
Loosen the pulse.
What do you think?
Tamponade from pneumomedius sinum.
And so this needs urgent decompression as they do here.
Pulse is coming up. Nicely done.
Hey, what the hell are you doing?
Fine. Leave me alone.
You can't do that.
Back off.
Oh my God, this dude recording stuff. I've never seen someone recording other patients in hospital, but I've walked into a bay several times and seen patients like taking selfies, you know, with their drips in their arms or with their injuries. And when you catch them, I think they feel a little bit embarrassed.
The patient's gonna have to get by with a liter of saline.
No, she needs blood, not crystalloid. Can she go to surgery?
So even rationing 1 unit of blood per patient, you know, they're running out of blood. We have a phrase in medicine that we should replace like with like. So this woman's losing blood, so she needs blood. We can give a small amount of fluid in trauma, but the danger of giving too much is twofold. Firstly, it's going to dilute the clotting factors in the blood, so hindering the ability of your blood to clot, making bleeding worse. And secondly, it'll increase the blood pressure, meaning any arterial bleed is gonna start bleeding more. So they are really in a lose-lose situation here. Maybe a bit of fluid, but the patient needs blood or needs to go to the OR.
Hours to screen for HIV and hepatitis.
I have neither, and I donate all the time. Please.
Fuck it. If the patient's gonna die before they get to the OR, then the benefits outweigh the risk.
Sorry. What? What is happening now? She's going to donate the blood herself. I'm kind of beyond words on this one. I feel like the realism so far has been just amazing, but I do feel like we've kind of gone off the edge a bit here. Of course, never say never in medicine. Strange and illegal things happen in hospitals all the time. Like the other week when a doctor CT scanned their own cat. So thinking about that, this is becoming more and more realistic the more I think about it.
There you go, there you go.
How's she doing?
Yeah, 500 of saline in. She's barely with us, Mo.
Okay, well, this unit of whole blood should help.
I mean, talk about doctors as heroes. We're literally giving our blood now for the patients.
Where's Stefano? Hey, Rich. How you doing? Oh, you got shot in the face? No, injured on the other side. Neck. Above his vest. Cheek is the exit wound. Okay.
So we see a police officer that's been shot in the neck, and we see the exit wound on the face. As we see here, very accurate that exit wounds are typically bigger than the entry wounds. And in our primary survey assessment of a patient, the airway and catastrophic bleeding appear right at the top, as these are the things that will kill you quickest if we don't do something about it. With bleeding and potentially swelling in and around the neck, we definitely need to get a definitive airway into this patient. Otherwise, he could suddenly get an airway obstruction and be dead within minutes.
Hey, what's up with the SWAT team?
It's just a precaution in case the shooter heads this way.
Is that a possibility?
There was some chatter.
Are we gonna be safe out here?
Should be now.
Focus on the patients. Focus on the patients.
Oh, shit. So there you have it, another absolutely phenomenal episode of The Pit. I can understand why you wanted me to check this one out. Everyone involved in the show should give themselves a pat on the back, because that gives such a true sense of what needs to happen when, you know, you have a tragic event that unfolds like we see here. And the characters that we know and love, we've seen their daily grind, and now we see them step up in emergency like this. And that's really cool to see. And the medicine as well on screen was as realistic as ever. I mean, that blood transfusion happening between the staff at the end, that was a little bit mad, but you know, we'll let them off that one. And if there's anything I've missed in this episode, or stuff I've got wrong, or stuff you want to know more about, then I love hearing your comments, so please leave them down below. And if you want me to continue this series, then I'd love to know about that too. And if you like this video, give it a like and consider subscribing. It really helps me out. Thank you for all your continued support on the channel. I hope you're all well, and I'll be back soon.